I wanted to go ahead and introduce Michael for those who don't know him, Dr. Fine, for those who don't know them. First off, I just want to share my screen so you can see this very debonair photo of him. One second. Check that guy out.
That's a scary thought, huh?
Yeah. And I'll just share, Dr. Michael Fine is the Chief Health Strategist for the City of Central Falls, Rhode Island, and Senior Population Health and Clinical Services Officer at Blackstone Valley Healthcare Incorporated. Dr. Fine guides a partnership between the city and Blackstone to create the Central Falls Neighborhood Health Station, the U.S. first attempt to build a population-based primary care and public health collaboration that serves the entire population of the place. Dr. Fine served in the cabinet of Governor Lincoln Chafee as director of the Rhode Island Department of Health from 2011 to 2015, overseeing a broad range of public health programs and services, an organization with 450 public health professionals and a managing budget of $110 million. He has been a family physician. He is a published author and has done lots of incredible things in the field of medicine, but to be able to focus on his presentation, we can send out his full bio at a different time. I just want to publicly thank Michael for the work he has played in helping the clergy at Temple Emanu-El and the leadership at the synagogue try to navigate this issue of the coronavirus. And even before Purim, back at the beginning of March, was already beginning to advocate strategies and let us know what our response ought to be and how the synagogue and religious communities can play a role in helping to flatten the curve. And so I turn it over to you, Michael. I'm gonna actually make you the, I'm gonna spotlight your video so everyone can see you. And if people have questions or wanna make comments, I encourage you to put them in the chat box. How does that sound, Michael?
Sounds good. I'm not sure I'm good enough at the chat box, but we'll do our best.
I'll be here, so I'm happy to feed you questions and things like that.
That's probably helpful.
Okay, go for it.
Thank you, everyone, for jumping in tonight. I wanted to talk early, talk quickly, as soon as I began to understand some dynamics that I think it's important for everyone to understand. I think everyone now knows that coronavirus is a virus that's relatively new in its current incarnation to human beings. And so it probably crossed over from bats through a wet market in Wuhan, China on November 17th or so, we believe. It is new to us, and it's a virus without treatment and without a vaccine. So we are 100% of us are susceptible to it. And that's the challenge that we're really faced with, that essentially all of us are going to get it at some point, and probably at some point in the next year or two. For most of us, well, actually, we now believe that for 25 to 50% of us, it will be completely asymptomatic. And for another, sort of 40% of us, 50% of us, it will be mild disease, a sore throat, a cough, a fever. We're now hearing that people sometimes show up with stomach issues first for a day, and sometimes people lose their sense of smell and taste for a day or two before the manifestation of the virus. It has some effects on the heart that we hadn't understood before. We're getting to know it a little better, but for some small subset of people, perhaps 5 to 10% of the population, it can require either hospitalization and an intensive care unit stay and needing a ventilator, and is lethal for some small percent of the population, particularly people who are over 70, 75, and have more than 1, 2, or 3 chronic diseases or conditions. And because so many of us are likely to get it at once, as it moves through the population, if we don't do something to change the population dynamics, we will have many more people admitted to the hospital than we have hospitals, and need many more ventilators all at one time than we have ventilators. And it's in that some small subset of people the people who need ventilators, and the number of which is more than we have ventilators, that's where we would see excess mortality, unnecessary deaths, if we don't slow down the progress of the disease and try to get it to move more slowly through the population as a whole. Sorry, that's my asthma cough, don't worry. If we can slow it down, then instead of having, like 5,000 people at once need a ventilator, we're hoping that we'll drop it to a couple of hundred people a week. And that couple of hundred people a week is a number close to the number of ventilators we have access to, and we can match our resources to the need if we can slow it down. And we've been slowing it down through a process that many people have heard of, called social distancing. It basically is the notion that says that I'm muted. Am I okay?
Now you're okay.
Okay. The idea is that if you don't see many people, and if you're not in the same room with someone who has it, you're less likely to get it right away. Remember, you're going to get it eventually. All of us are going to get it eventually. And it's important for people to know that and remember that for most of it, it's asymptomatic or mild disease. So there's nothing to fear but fear itself. However, the idea is if we can slow it down, then we can match resource to need. And we hope we will have the least loss of life and serious illness if we proceed in that way. The piece that I don't think has been made terribly clear is the piece about household transmission. In China, most of the disease clusters were from household transmission. That is, when a number of people got it in one place all at once, it was usually households who were spreading it to each other. And a substantial number of people in China actually got the disease from a household contact, not necessarily from someone at work or someone they met on the street, because it's a highly transmissible disease that's transmitted when people cough or sneeze. It's not very complicated. If you're in the same house with somebody who's coughing and sneezing and it's transmitted that way, that's what's going to happen. Our strategy at the moment is to say, if you are sick, stay home for 7 days and try to isolate yourself. And what I don't think we've done a terribly good job of at the moment is telling people in a clear way how to isolate themselves. And that's part of why I wanted to have the conversation tonight, to make sure people have a better sense of that. And the other thing that we haven't done, and I think is going to be recommended in the next week or two, is we haven't done much with masks. We have said, you don't need a mask if you're not sick. And we've sort of said you could use a mask if you're sick, but we haven't been very clear about it. Because of the character, and the reason we did that is actually because we didn't have enough masks for healthcare workers. And so we were trying to conserve masks because we knew that we needed our healthcare workers, and that's entirely logical. But we kind of forgot that people could make masks at home on their own, and you don't need to go to the supermarket or to the drugstore to buy masks. And the evidence actually suggests that masks may be helpful in preventing people with the disease from transmitting it. It's not yet clear how helpful masks are in keeping someone without the disease from getting it from somebody else, but there's certainly no harm in masks. And that sort of suggests some opportunities that we haven't recognized. And there's one other small bit of detail that I was thinking about over the weekend, and we're starting to work on in Central Falls and Kentucky. And that is that during Ebola, Ebola in Liberia wasn't stopped by doctors, it wasn't stopped by nurses, wasn't stopped by hospitals because there really aren't very many in Liberia. It wasn't stopped by healthcare workers really at all. It was stopped by an organization called Partners in Health, who decided that they could go into communities and work with communities and get communities to begin to understand the dynamics of the disease transmission, and thus change how they behaved in their own communities and change the outcome. And that work, that community organizing work, which was really what stopped Ebola. And I began to realize that we could put that to work here, particularly because it's not clear that we're going to put up something called isolation hospitals, which is what the Chinese used to great effect in Wuhan to stop the progress of the disease. So what does all that mean? All that means is a couple of things. It's worth making clear to people, first, that when you get sick, or even before you get sick, starting today, everybody should find a room in their house that I kind of call a hibernation room, and bring into that hibernation room, a bunch of books, stuff to read and study, a TV if you have to have one, a computer, a cell phone, maybe a little dorm refrigerator, a laundry basket, a big garbage can, because should you get sick, the right thing to do is for the person in the household who's sick to go into that room and plan to spend 7 to 10 days in that room, to spend time in that room, to stay in that room until you've been without a fever for 7 days when you're not taking aspirin or Tylenol. To be without fever, for 3 days. So the recommendation is spend at least 7 days there, but you might make it longer if your fever and serious cough last longer. So it's important for people to know to set up the isolation room, to plan to move into the isolation room if they get sick. And I think my suggestion, though at this moment it's my suggestion, I don't have the CDC behind me yet, and I think they're getting there, is that everybody have masks that they've made themselves, and that anybody who gets sick put a mask on and keep the mask on during the time they're sick, which will help prevent the dissemination of these respiratory droplets. But I think there's yet a more interesting opportunity that comes out of this. In Central Falls and Pawtucket, we are now suggesting that every household make for themselves 7 masks for each member of the household. And they do it together. It's kind of a family thing to do together. So that, the good thing is, first of all, they'll have the masks to use and they can change them every day if there are 7. The other good thing is, by the process of getting together to work on them, that helps parents and kids and anybody who lives in the house begin to think about this process of transmission and understand what you have to do to break the chain of transmission and to delay the spread of the disease. And so we're beginning this whole series of Zoom meetings. And we mean to have many every day. We're going to have Zoom meetings for churches and their congregations. We're going to have Zoom meetings for community organizations. We're going to have Zoom meetings for any organization where one set of people will pull other people together and basically take them through what I just took you through. At the same time, we're putting together instructions for how to make a mask and some other things up on a website, which should be up and running in a couple of days. But the opportunity is to begin to work inside our communities and get people themselves involved in, making masks as the short-term goal, but then really as the long-term goal in thinking together how we prevent transmission and slow this disease. Because, you can have the governor say this, that, or the other thing, And not everybody listens in the same way as people listen when people from their community talk to each other. Rabbi.
Michael, we have a question. Are you suggesting making masks for when you don't feel well in your own home and preventing transmission in the house resonates? Are you suggesting people wear masks when they go out for walks, when they're out in public in general?
There is no current consensus about that. There's no harm in doing it. And I think you're going to see an emerging consensus that argues for doing that. Though it has not been recommended yet. As I'm reading the literature and listening to this discussion, I'm pretty sure that's where we're going, but that's not the current recommendation, even though there's no harm. What I'm really suggesting is that everybody makes 7 masks for everyone in their household and use that as a way to get people paying attention to this. You know, we gotta create a hibernation room. And one other thing that hasn't been well understood, if one member of a family gets sick and goes into the isolation room, then it is suggested that everyone else in the family stay inside the house for 14 days until you find out whether the other people in the family are sick or going to get sick. And I don't think we've done a good job discussing that, but it's an important piece of how we keep this disease from spreading further and faster than it's spreading already. Other questions?
Yeah, so I'm going to go ahead and post. I think, Michael, you sent me a link for how to make these masks, correct?
Right.
So give me a second, folks, and I will go ahead and put that in the chat box so people can take a look at that. Jane is asking, is it possible someone could be immune to this?
I'm sorry?
Is it possible that people could be immune to this?
It is highly unlikely. We know of no native immunity to this because it's different enough from the 4 types of coronavirus that we've identified in the human species. So it appears, I mean, the danger to us as a population is that none of us are immune. And the danger is that we're all basically going to get it at once. And that's what makes it different from flu, by the way.
Also, and obviously to remind everyone that you can also be asymptomatic.
And so you can be asymptomatic. That's not so different from other kinds of coronaviruses and even really from flu. There are a number of people who have flu who get infected with flu and don't show symptoms. We don't know what that number is, but we know it's real. But to give you a feel for the difference, each year, 5 to 10% of us get the flu. And that's it, because we have enough existing natural immunity and enough of us get the flu vaccine that it doesn't spread through the entire community, but only hits the people whose immunity has waned. And they're usually the only people who get sick. Whereas this, as it comes through this year, has the capacity to infect all of us within a few weeks.
So a couple of questions we've also received are, how is it possible that someone who has it in the house doesn't spread it to others? If someone in the house had it and recovered, are the rest of the people in that house sort of immune, or have they built up immunity? And are you suggesting that people should begin wearing a mask only when someone in the house is symptomatic? So it's not you're suggesting everyone should wear masks all the time at home. It's when people are symptomatic that everyone in the house should start wearing masks as well.
Actually, I'm suggesting that we have enough masks for each person, but that when one person is symptomatic, the symptomatic person wear a mask and stay in that isolation room. I don't think we know that it's necessary for the other people in the family to wear masks. It won't hurt, but it's not as big a deal as the person in the isolation room who's sick to wear a mask. Let's see if I can remember the other questions.
Sorry, I was giving a bunch of them.
If one person has had it, does that make the other people immune? And the answer is no, not unless they each had it. Though some of the people other people in the family may have had it asymptomatically. And that will, we believe, make them immune, but we're still learning our way through this disease, and we're not entirely sure about the relationship between, about having it asymptomatically and immunity. But in most other viral diseases, when someone has a disease asymptomatically, that does usually render reasonable immunity. And there was another question packed into there, I think.
Let me take a look here. So Jeff, we'll get to that one in a moment. No, I think that answers that. I think some people, so a couple other, these are more broad questions. And that is, okay, so number one is, can vitamin C and zinc be effective?
Well, the answer to any question in medicine is always yes. We have no way to know whether it is effective for this. So could be, but I wouldn't count on it.
Is it possible that a vaccine will be developed before everyone gets sick?
It is possible, but I think everybody's best estimate is not likely. Everybody's sense is that a vaccine, I was originally hearing it was going to be 6 to 9 months, in which case the answer might have been yes. But now I'm hearing more 12 to 18 months, in which case the answer is probably not.
What should we expect? These are the magical questions. What should we expect in the second wave of the virus? More closings. I think sort of baked into that question is, what does this look like 3 months from now, 1 month from now? What are you envisioning?
You have asked the hardest question, or that is the hardest question. 1 month, first of all, I expect that this period of closure will be 3 to 4 months. So
From when?
From now. I think we're down for 3 to 4 months. If we get up earlier, it'll be a good thing, but I wouldn't count on it. I'm just watching the rate of rise of the virus. We're really, with all, what you do when you do this kind of closure and social distancing is you slow the transmission, and you make it so the peak may not come for 3, 4, or 5 weeks. And if it peaks in 3, 4, or 5 weeks, if it peaks in 5, then it has to take another 5 to go back down again. That's 10 weeks altogether. Ergo, 3 to 4 months. The problem is what happens when you think about bringing kids back to school. The projections I've seen is that we start all over again. And because it turns out that it looks like kids in school are really the vector, the way the disease is passed from family to family. And that's the real difficulty now, is figuring out how we're going to manage it after that before we get a vaccine. There is a school of thought, and I think this is where the governor is, that we should do what the Koreans have done, which is, sort of tamp it down as hard as we can. And then every time, and come up with some very sophisticated electronic tools, really watching cell phones and cell phone movements, using big data to figure out whether someone's been exposed and needs to be isolated. The real hard thing is going to be around isolation hospitals. I think the governor is trying to avoid isolation hospitals. And yet the isolation hospitals are places where, for everybody who gets sick, they get pulled out of their house and brought into a special hospital where they stay until they've recovered, so they don't infect other people in their household. We're not doing that now. And that, to me, is a potential weakness in our approach. And until we get them, I think it's going to be very hard to keep people from spreading inside households. And once you can spread inside households, putting kids together in school, that you're back to Jump Street. And so, I don't know where we're going. I don't know how we're going to do this just yet. I'm fully supportive of what we're doing now to stop its spread, but I'm a supporter of isolation hospitals, unfortunately and painfully. And I think we need to be thinking of other approaches, which for me include building quickly more intensive care units and getting more ventilators so that, you know, it's so that as it spreads through the community, we can take care of the people who are sickened by it. And I'm beginning to think about using isolation, not just for people who are sick, beginning to think about whether we need to use isolation for people who are vulnerable so they don't get sick, that may be part of the trick at the end of the day.
Do you wipe off your, and I know there's no pattern to the questions we're asking. I'm just trying to glean. Should one wipe off their groceries when they come in?
No science, no harm. You know, this is a moment where we just don't know one way or the other. Wiping them off is one thing. Another trick is to put them aside for 3 days because, you know, it looks like the virus lasts only 24 hours on paper or cardboard, lasts 3 days on metal or plastic, 3 days, and you should be cool.
Can the virus be transmitted by exchanging money, using cash, coins?
You know, the answer to any could be question in my world is always yes. Seems relatively unlikely, but you know, it depends on how often the people who are you are exchanging the money are washing their hands.
Talk about malaria medication, some of these different medicines that people are using. Are they promising? Do you think they might work, or could that be a path to helping people cope with the virus?
What I think doesn't matter. The evidence, there's a small study of 25 patients from Marseille in France that suggests, and it's not a good study, it's not a well-constructed study. So in that one study, they looked like one of these medicines was effective. There's a theoretical explanation for why it might be effective, but I don't think we'll know till we have a chance to give it to enough people and get the science done. You know, I think jumping to conclusions before science is dangerous because all medicines have side effects. And if we start using it broadly, and then it turns out that it wasn't effective and people had serious side effects, then we run the risk of doing more harm than good. So in this realm, I'm a great believer in sticking to the science.
If you if you are able to transfer the disease, transfer the virus before you are showing signs of symptoms, why is it effective to wear the masks, or for the person who is symptomatic to isolate themselves if they've clearly been in contact with family members before they became symptomatic?
Well, we don't know how much spreading they were doing before. We know that you become most able to spread the disease when you're coughing and sneezing, when you're symptomatic.
I see.
And we hope that maybe you didn't until you go into isolation. And then we put you in isolation, and we hope the isolation keeps you from spreading it to family members.
I see.
This is exactly why people in China and other places are using isolation hospitals to get people out altogether. But even that, as was just observed, doesn't prevent the transmission from an asymptomatic person or a person before they become symptomatic. For most viruses, people are symptomatic for a day or two before they become clinically ill. And I think we may be out of time. I would never, ever want to get in the way of Cantor Mayor.
So we can keep going with questions. We're okay for a few. We'll do an extra minute.
Okay, good if everybody is.
Yeah. So what I'm looking at, how do you say that if everyone is eventually going to get infected, how do you imagine eventually, when do we go back to work? What does it look like? And I wonder if you could share some expertise, so maybe how things might be different in Rhode Island, or are there things that we could do differently in Rhode Island, or is the way we will respond to this the way that every state is going to respond to this?
Well, we go back to work really, most safely in one of two situations. either when 70 or 80% of us have had it, and we can prove that by doing something called community serologic surveys. When we prove that, then we know that most people have had it, and then essentially we get something called herd immunity. It doesn't spread because most of the people who are exposed are already immune. So either we get herd immunity from many people having it, or we get herd immunity from a vaccine. Well, is Rhode Island different from any place else? You know, how is this state different from all other states? You know, we are just like every place else. You know, we got to close schools relatively early, and we shut some things down, many things progressively, sort of early. So that may slow things some, but we are, you know, if you prick us, do we not bleed? I mean, you know, it's like we're no different than anybody else fundamentally. We're in places like Central Falls, Pawtucket, you know, the parts of Providence and Cranston and Woonsocket, we're very densely populated like New York, which puts us at some risk. And other places like, you know, places in the middle of nowhere like Scituate, we're not so densely populated. And you know, that makes us more in those places like, you know, Vermont. You know, my guess is we are 2 to 3 weeks behind New York. We will get a surge. The surge is coming, it just hasn't come yet. How intense it is, we don't know yet. I worry a little bit that from an infectious disease perspective, that we haven't closed all workplaces and haven't, you know, totally confined people to their houses, which is what they did in Wuhan. And that will make it so that there's a little more disease than there was in Wuhan. I worry that we haven't started isolation hospitals, which is what they did in Wuhan to really shut this thing down. So that may make it that we don't get as complete a reduction in the number of new cases. In Wuhan, they went to 0 new cases a day about a week or 10 days ago. But you know, they're just as much at risk as we are from reoccurrence of disease when they open up again. And that's going to be the challenge until we get either herd immunity or a vaccine.
Do you find that obviously people should still take care of themselves? And are you finding most doctors are, people should still do their general checkups? Have most medical procedures moved and checkups moved on to telemedicine or phone calls? Should people be seeing their dermatologist, or there are sort of like routine health things that people need? Should they still be going to those appointments, or should they stay home?
I think at this point in history, it's wiser to stay home unless you have something that feels urgent or emergent. And it's worth talking to a clinician to assess whether it's really urgent or emergent. You know, there are plenty of time for general physical exams. This is not the time. Most medicine is now conducted over the telephone, and that works most of the time. And we'll get better at it over time, and that's okay. You know, I think it's as simple as that at the moment, and probably for the next 2 or 3 months.
Should we be concerned with people's dogs going to the vet?
Not for the dogs.
Okay.
We don't know whether dogs get this or not, but you know, anytime somebody is within 6 feet of somebody else, you know, there is a chance right now this disease will be transmitted.
Someone asked, are we just spreading this out the time it will take are we just spreading out the time it will take for all of us to get the disease, and not whether or not we will be getting it?
Correct.
And this is the whole flattening the curve initiative of trying to
flattening the curve, because, you know, because if we don't flatten the curve, so many people will need a ventilator at one time that we'll run out of ventilators, and we will have excess mortality, unnecessary deaths in the people who needed the ventilator and there wasn't one for them. There's another approach to this in some ways, which is build more ventilators, build more ICU units, and do it fast. And I'm actually there's a fair amount of discussion about this in the literature, and I'm enthusiastic about that approach. I wish we were doing that more. But as a nation, we haven't exactly approached this in a focused and coherent way.
What about things like donating blood or getting blood tests? If you have a chronic condition where you go to the doctor regularly, how do you lessen the chances of infection as you go in for these periodic treatments?
Do it as rarely as you can.
This is really
I have a cousin who's unfortunately in the intensive care unit in Montefiore Hospital in the Bronx, one of the great hospitals, who has been there for a month. They kicked his family out 10 days ago, and he got coronavirus in the hospital from staff somehow. And so there is no, and Montefiore is a great hospital. There is no safe place at this moment and no safe way, or no, it's not so unsafe to get the disease, but no way that you can prevent getting the disease if you are in contact with any person. I think I sent Shosh a list of 5 or 6 fairly simple things people can do. I don't know if that's displayable.
Yep, give me a moment.
But, I made it very simple, not, no groups of 50 or no groups of 20 or no groups of 10. From my perspective, it's avoid other people, period.
Let me cancel this. Can people see the PowerPoint?
I can see it. I hope others can.
Yes.
Yes, we can see it.
Yes.
So I'll let you all read that for a moment.
Question, Dr. Vine?
Sure.
Yeah, this is Howard. Is a surgical mask effective?
Well, there are different levels of effectiveness of masks. The best mask, the most effective mask, is called an N95. But a homemade mask is better than no mask. It looks like there are a couple of designs floating around. I think we may have forwarded one, I don't remember, where you basically sew together 2 pieces of cotton, and in the middle of the 2 pieces of cotton you put a paper towel, and that is almost as effective as an N95.
Can you talk about if a person quarantines for 2 weeks, do you think they can join another family? In other words, if you want to move in with your relatives or you want to move in with friends, if a person says, I'm willing, I know this is going to take a while, and I don't want to be alone, or I want to be with my family, can you advocate for a person sort of practicing extreme isolation, or whatever term we want to use, and then joining another family?
I think it is not unreasonable, but it's none of this is perfect because of the risk of asymptomatic disease. So if a person isolates for 2 weeks, and this is where our being new with this disease is a little tricky. There was some original data that suggested most people who were asymptomatic became symptomatic over time. But my guess is it's not perfect, and there probably is some set of people who are asymptomatic, stay asymptomatic for a period of time. We don't know exactly how long, and can still spread the disease. So if a person isolates for 14 days and joins a family, it's probably pretty good, but it's not perfect. But remember the other side of it. The other side of it is we're all getting this disease, and for most of us, it's mild. So for me, if the family they were joining were all young and healthy, then I'd think there wasn't such a problem. If the family they were joining were 85 years old and had diabetes, high blood pressure, and heart disease, I might wait a little bit. and see if, see what happens, see if, we all get the disease anyway, see if we get a vaccine, try to go slow a little bit based on the pre-existing risk of the people who are getting together.
Are we finding new data about kids? Are kids equally as likely to get sick? Are there symptoms more severe? And what is the likelihood that summer camps will be canceled and school will be delayed at next fall?
We are learning new things about kids as the number of people who have the disease increases. And we're finding that it behaves pretty much like influenza in kids, which is kids get influenza, they just don't get terribly sick from it most of the time, but some tiny subset of children actually get very sick from influenza and from this. And this tiny subset, we will have some deaths who are children, very unfortunately, but it's a tiny number. In the United States from influenza, we see 25 to 60,000 deaths a year in the United States, with 25 to 50 million cases of influenza. Of those, we see about 100 to 150 or maybe 200 deaths in children out of 30 to 60,000 deaths a year. And I suspect that the proportions will be similar, but we just don't have enough experience with the disease to have really seen its impact on children at the end of the day. But it appears that it's in children basically a mild disease with some occasional exceptions.
If we were to all get tested today, what percentage of us do you think would have already had it and didn't know about it? Or what percentage of us would have been asymptomatic and therefore know they've sort of passed the scary part, so to speak?
In Rhode Island, I wish we could have that kind of testing, because it would tell me part of the many things I don't know about this disease. But if I had to guess today, depending on city, if I had to say in a city, which is a little easier for me to guess than in the country, probably 3 to 5 or maybe 10%.
That's a long way from that herd immunity that you spoke of earlier.
Exactly. And that's a wild guess. I have no data
Right.
to make that. But Dr. Phillips, I think, is on, and I don't know, Bruce, if this is your experience, but when I'm seeing patients, I'm not seeing many people who are sick, and that suggests to me that that we haven't seen this disease widespread, or anywhere near as widespread as it's going to get.
Yeah, Michael, there is one other piece of data, I think, that of the people I'm testing who at this point all have symptoms,
Right.
only 10% of them are showing coronavirus.
Right. Which,
So that's the population that you think there would be many more positives if it was widespread in the population right now. So I think
right. That's why, that's why I gave you 3 to 5. In Rhode Island, the number of positive tests are greater as a percentage. You're testing in Massachusetts, but they're going to equalize over time.
Okay. Any thought about summer camp?
I'm sorry?
Any? I guess this is one for kids. I'm guessing kids are curious. Kids are curious and parents are curious. You think summer camp is going to be in session?
Do I have to be the bearer of bad news?
I guess it depends if you're the one paying for summer camp. So go ahead.
I've learned how to answer a question with a question.
Yeah.
But I think it's unlikely.
Okay.
Unfortunately.
What about false negatives on tests?
I haven't seen the numbers, and a lot depends on the skill of the tester. But I think all comers, we're hearing about 70%. Let's see if I have this right. False negatives. Well, false negatives are about 30%, I believe.
Is that high or low comparatively to other tests?
Way higher than we'd like. It's not at this moment a terribly sensitive test. Now and remember, testing is going to change about every other week and a half. So we went from no testing to Tomorrow, we can test 1,000 people a day. And then in 2 or 3 weeks, we will have a different kind of test, which probably uses saliva or nasal secretions and is a 15-minute test that's done right on site. That will become more widely available over time. So the testing story is going to change, every time the weather changes.
Has the virus mutated, or is there a concern that you might get it once and then get reinfected, or a different strand will just keep brewing?
I don't know the answer to that. I have heard that coronaviruses in general do some mutating. I've heard some story about mutation, but I haven't seen enough in the scientific literature to answer that question precisely. And that's an important question because mutation makes it so that the newly mutated version may be a virus that we're less immune to. That's what happens with seasonal flu. The flu mutates, and so it manages to infect people who were previously mostly immune.
So in closing, final thoughts, or if you want to give a summary, what should people take away from tonight? What are there 1 or 2 or 3 main things you wanted to get across tonight?
The major thing I'd love to get across is an interest in, as a community, working together to have a community effort to make 7 masks for every person in every household, and do it ourselves and share the experience of doing that, and then spread it to other religious and faith communities. So we bring a sort of bottom-up approach to controlling this disease. In the process, I think we will learn a lot more about how it's transmitted and a lot more about how to protect ourselves.
Wonderful. Beautiful. Peer pressure is often thought to be a negative thing, but I want you to know how many people tuned in tonight in such short notice because they wanted to hear what you had to say. And I'm hoping as you look into and you see all the different people who are here assembled, we can use peer pressure to make this a regular weekly check-in where people can bring in questions and you can update that. And I won't ask you this second, but I hope you will consider joining us regularly.
I would be honored to do that.
Okay, well, that was easy, folks. All right, friends. I want to thank Dr. Fine for teaching us this evening, and really your calm presence, your fact-based approach, and also the frank way in where you're describing what we have to do, and that there are things that we can do. All right, we all have to be cautious. We all have to be careful, but there are concrete steps that we can take to help protect ourselves and our loved ones. And I hope that we all go home. If you look through the chat, you will actually see the links that Dr. Fine sent us about how to make our own masks, and we can send this conversation out to the congregation with those links as well, so everybody can have a chance to make them. And if you want to get creative, then we can have a day when everybody can show off their masks and how beautiful they look.
Have a mask contest and translate into Hebrew the 7 Masks campaign.
So that's what we can do. We can have a mask parade or something along those lines. I saw Bruce Phillips wrote something along the lines of, had we done it at Purim, we could have decorated them. So I think we can make it part of what we do here. If we have 7 species in the land of Israel, we can have 7 masks in our homes in Providence. So I'm going to thank you once again. I'm going to go ahead and turn over the controls over to Cantor Mayer for his liturgy class.
Dr. Fine, how
Reach
long
our
do we
co-op,
wait to see,
Doctor.
how long do we wait to see kids from another state? We have a daughter who's by herself, and we have a son who has 2 kids that we usually help out a lot.
I don't have an easy answer. Spend a lot of time on Zoom and Skype. And, there's a point at which you make a calculation. Remember, we're all getting this disease. And, the ability to be disease-free is not the only value that we have.